Hi guys. So for those that don't know me, I'm Dr. Sullivant. I'm one of the chiropractors downstairs in the therapy department. Um, just a little bit about myself. So I've been a chiropractor for about 3 years now, but I also have a specialty in clinical neuroscience. So I did over 300 hours of postdoctoral studies in clinical neuroscience, including clinical neuroanatomy and functional treatments to improve all types of neurological conditions. And then I took a nice board exam to become a diplomate of the American Chiropractic Neurology Board. And so here at Insight, we mostly do pain management, chronic pain, right? And we do a lot of auto downstairs. But I'm going to talk about something today that I get to do, in my off hours, which I like doing. It's not really our bread and butter patient here, but I work with kids on some of my off hours, and we'll talk about that going forward now. So before I get started, I just want to make a thank you to Dr. Robert Melillo, Brain Balance, and his book, Disconnected Kids. This is sort of where I've gotten a lot of this information, training on this type of care. So he's kind of the doctor that's pioneered the clinical neuroscience work with kids. So let's talk about disconnected kids for a little bit. So the type of work that I'm going to be talking about, what the kids that we work with, they all suffer from all types of different conditions. Autism spectrum being one of the biggest ones. In 2018, the CDC now is approximating that 1 in 59 kids will have autism, boys being 4 times more likely than girls. ADHD as well is 10 times more common in this generation than it was a generation prior. And 1 in 5 students has a language-based learning disability. ADHD medications, those are the most commonly prescribed in kids. And so these are kind of like really staggering statistics. Really alarming. And, a commonality too, we know that there's a lot of issues in our food, especially here in America. We've got a lot of crap in our food, a lot of nutritionally bankrupt food. Kids are on phones, tablets, way more than they ever were at this generation. They're estimating that they're at least on a screen for 7 hours a day, which is a lot. And I'm sure most adults are close to that too. So, there's all these different conditions, which I'll talk about in a second, but, all these different symptoms, all these conditions, but really when you boil it all down, it's one problem, that there's this functional disconnection in the brain. And a lot of these conditions, when you break it down, the symptoms, there's commonalities between all of them, things that each kid struggles, and it may present differently from kid to kid. I mean, autism is a spectrum, as we know. ADHD has its own challenges. There's oppositional defiant disorder, OCD, learning disabilities, language disabilities. But when you start looking at each kid, you start seeing a lot of commonalities in their symptoms. But what we know now is that we can kind of group them under this functional disconnection syndrome, and that these conditions affect our behavior and our learning. And it's really due to an imbalance in electrical activity, especially when you look at one hemisphere versus the other in the brain. We have a weak hemisphere compared to a strong one, and there may be a decrease in electrical activity in one side of the brain and an increase on the other side in some of the higher functioning areas, and this is where we see those deficits. And that's why, too, it can present, different from kid to kid, because where one kid may have a deficit, another kid might be having an acceleration in that higher functioning area. So that's why, some kids on autism, with autism, some are great with, memorization. Some are great with numbers, some music. So there's different parts of the brain that are being higher elevated and others that are lacking that electrical output. So the conditions that we work with, and again, we kind of talked about some of these: autism spectrum disorder, Asperger's, ADHD, dyslexia, nonverbal disabilities, OCD, ODD, sensory processing disorder, Tourette's. And like we said, when we boil it all down, we see a lot of common symptoms between these kids. So some of those common symptoms, and these are more general outlines, but when you start breaking them down, then you see, we'll talk a little bit more about what that means. So poor body awareness, kids knowing boundaries, physical boundaries, other people's physical boundaries, having the ability to, tell, like, telltale signs like, I need to go to the bathroom, or I need to not touch that, or things like that. Poor gross fine motor skills, persistence of primitive reflexes, which we'll talk about what that is in a second. Poor eye coordination, social skills. They have abnormal emotional reactions, outbursts, anger, temper tantrums that are just uncontrollable sometimes. Sensitive sensory systems, and so this is, vision, hearing, touch, smell, where those stimulus are very big to those kids, and especially in the autism community, you'll see where they put on things that are like autism friendly. Like I just saw online that some movie theaters in Michigan are having an autism friendly night where the lights are going to be higher in there. It's not going to be as dark. The sound will be lower. The crowd might not interact as much, so that those kids can handle being at a movie and do those things and not feel like they're overwhelmed with stimulus. Compromised immune systems. A lot of these kids have allergies, poor digestion. They're sensitive to certain foods. I think that's down there on the list. Yeah, food sensitivities, which that kind of can lead into what we call leaky gut syndrome. When they are eating these things that are constantly inflaming their gut, then the gut becomes more porous to things that were not designed to absorb, and then that in turn can trigger an antibody response to those foods, and then we see that kind of spiral out of control, and those food sensitivities become more and more of a problem. A big one it being like red 40 dye, or any dyes for that matter, gluten, dairy, those sorts of things. A lot of these kids can't tolerate those in their diet, and we see when they're taken out of the diet that there's a major improvement in behavior. Academic struggles, cognitive awareness, poor cognitive awareness. So, with these kids, when they're coming to me, I'm not diagnosing them with autism, ADHD, any of these things. That's out of my scope. They have a diagnosis usually when they're coming to see me. What I'm trying to decide is there a weakness in the brain? Is it one side more so versus the other? And what does that look like for those kids? So just kind of in general, when we're looking at the two hemispheres, left brain kids, they're going to have, poor skills in like school skills, math, verbal, spelling, reading, those sorts of things. So you're going to see disorders like dyslexia, dyspraxia, acalculi, and those are things like where they have an inability to, read properly, to do math properly. They may not be able to use their hands in a certain way properly. So those are the types of things we see with left brain issues. Now, those aren't really always the kids that I'm seeing, because they don't tend to have these like huge outbursts, big behavioral issues. And so sometimes parents, they don't know that this is a thing that can work for those types of kids too. But the right brain kids, these are the ones where we see like the autism spectrum, ADHD, big behavior issues, hyperactive, outbursts. These are the kids that have a lot of allergies, autoimmunity, diet issues. They don't make eye contact. They miss the big picture. They have those sensitive issues. They don't have those boundaries, physical boundaries. They may not be able to focus and make, attention, or keep attention with people. They're impulsive, those sorts of things. So these are the kids that I tend to see the most, because these parents are, they're wanting to improve that behavior. And there's all different types of therapy out there. There's ABA, that's important in of itself as well. There's these brain balance centers, which does similar work that we do in clinical neuroscience. So these are the kids I tend to see more than the left brain kids. So the primitive reflexes that we talked about earlier, this is a big part of our program, and we identify in these kids if they have these primitive reflexes still. So what primitive reflexes are, when you're born, when you're a baby, you are born with these different reflexes that are there as like survival instincts, survival mechanisms. So, a baby knowing to breastfeed, a baby, if you've ever touched a baby's palm and they grab onto your hand, that's a reflex. Different reflexes for them to lift their head, things like that. And over time, as we grow and develop, these reflexes are supposed to be suppressed. They don't ever fully go away, but our brain works in a way that it starts to suppress them so that they're not there anymore. It seems like they're not there anymore. And really that comes from our frontal lobe, which is like all of our executive functions, higher functioning, our thoughts, what we do, our judgment, things like that. The main goal of our frontal lobe is inhibition. It's there to kind of be the gatekeeper of everything. It's there to kind of keep us in check and say, okay, don't respond that way. Don't have this outburst, or don't touch that. I mean, it tells us to do things too, but within, limitations. So ultimately, the frontal lobe is inhibition. And when that frontal lobe doesn't grow and develop the way that it's supposed to, we don't get inhibition of these primitive reflexes. And so with these kids, we test for some of the more common ones. These are the more common ones listed here. I mean, there's tons of primitive reflexes out there, but these are the ones that I tend to look for and the ones that we see the most in these kids that present. So when we do our exam with them, we test all of these, and each of these reflexes can kind of link up to certain symptoms that the kid might be showing. So with the Melillo reflex, this is our startle reflex. With these kids, when it's present, they may be hypersensitive, hyperreactive. They've got poor impulse control. They may have, emotional outbursts all the time. Another one that, tends to be big with these kids is the spinal galant reflex. And with that one, we may see, it's not listed on here, but bedwetting is a big commonality when that one is still present. And so we test for these, and then we'll talk about what we do once we know which primitive reflex or which ones are still present. So our treatment plan, we assess for these differences right and left brain. With kids, I tend to keep it pretty general because a lot of these kids can't communicate things effectively. I mean, the parents can. They can communicate what they see on their end and what they experience from their perspective, but it's hard to get the kids to kind of really convey, okay, this is a problem for me. And we can kind of pinpoint certain aspects a little bit deeper with these kids, but with kids, I keep it, pretty general to right and left brain to start. So we do an in-depth neurological exam, so that includes, the primitive reflex checks. We look at eye tracking, eye focus. We test muscle strength. We look at posture. We look at, hand-eye coordination. We look at the vestibular system as well, like their balance and things like that. We may also look at if the child's not already working on nutritional things and diet changes. We may look at that as well and identify if there's things we need to change there too. I also give parents a large checklist that's like 10 pages long, where I have them, check off different things that pertain to different parts of the brain. and different sides of the brain, and whether or not, these are things that the child struggles with too. So that kind of helps us narrow it down a little bit too. And then from all that information, we create a personalized treatment plan for each of these kids. So that includes, first and foremost, the primitive reflex integration. That's kind of where I start with most kids, because in order for us to make changes, we have to integrate those reflexes first. If they're still present, it's going to be a lot harder and a lot slower going of making changes with these kids. So there's exercises designed to help integrate these reflexes over time. And so we do them in office. We have them do them as homework. And they're pretty basic exercises. I mean, for the spinal galant reflex, it's a snow angel, which seems so arbitrary, and so you would think, what is a snow angel going to do for this kid? But that motion and doing it repetitive helps integrate that reflex. There's the rooting reflex, which is, that's one of the most basic primitive reflexes. It's right there from the start, right from birth, and that's, if you stroke a baby's cheek, they know to turn their head or open their mouth so that they can, do the sucking reflex and breastfeed or bottle feed. And so if that one is still present in kids, all we do is stroke the cheek, and we start working on desensitizing that area to that reflex. Same with the palmar grasp. If that one's still present, that one's there right from birth. We stroke the hand. We have them do fine motor skills in the hand. Another big thing that I do with all my kids is all this sensory stimulation with vibration. So that may be a tuning fork that we use to put in vibration sense into all their joints to wake those up. Another reflex we work on is crawling. A lot of these kids never crawled, or they crawled for a really small amount of time and went right to walking from, not really moving too much, rolling, and then they went right to walking. And parents think, oh man, that, when it's happening, they're like, oh, they're progressing so fast, but crawling is such an important part of growing and developing, and so it's not a step that we want to miss. So we work on those things. We work on, vestibular stimulation, rehabilitation, working on balance and coordination with these kids. I'm throwing them on the balance board, the wobble board. We're doing balance beam. We're making sure that their hands and feet are moving together as they should in a normal walking reflex, things like that. With some of the kids, we may work on the fine motor skills, the gross motor skills. We may work on timing. So another tool that we'll use is a metronome, an interactive metronome, where they're listening to a sound, a beat, and they're having to do something that times up with that beat. And then again, nutritional recommendations. And so with every kid, it looks different, and each plan's specific to them. And then we also adjust them, because especially in the case of bedwetting, a lot of kids that have bedwetting, they don't have the proper stimulation going on down in the sacral area, in the sacral nerves. And sometimes that's a problem with kids and they don't have these behavioral issues. So we definitely work on adjustments and waking up the mechanoreceptors and the joint mechanoreceptors through that, because a chiropractic adjustment is one of the biggest stimulations that you can give to a mechanoreceptor. So that's part of our protocol too. And touching on chiropractic in kids, it looks very different than with an adult. An adult, we're doing bigger movements, we're using more force. With a kid, sometimes we're doing a manual adjustment with them depending on their age. Sometimes it's just an instrument using a tool. And when it gets down to babies, it's finger pressure, because they're cartilage, so they don't have joints yet. So it looks different for each kid and where they're at in life.